One of the banes of every paramedic who works in a two-tiered system's existence is hearing the words, start a medic for chest pain, when a BLS crew is at the scene of an otherwise minor motor vehicle accident. Generally, chest pain from an airbag hitting the chest is not an indicator for upgrading the call to an ALS response. It's just not. Someone getting into a minor accident, looking fine, having stable vital signs, being able to self-extricate from the car, and they go, ow, when you push on their chest, does not automatically mean that you need to get on the radio and call for a medic unit. Applying that ACS is a medic call and chest pain is ACS, therefore chest pain is an MVA medic call logic to minor chest pain from a minor MVA is comparing apples to oranges. And frankly, I go to these calls and I ask, okay, you heard chest pain. Did you actually assess the patient, or did you just blindly get on the radio and call for ALS? Are there times when you should upgrade chest pain from an MVA to an ALS response? Absolutely, but you have to assess the scene and assess the patient. Don't just hear chest pain and then shut your brain off. An important question to ask the patient is, did you have chest pain before the accident? If the answer is yes, then the patient certainly could be having a cardiac event that led to them crashing their car, and that would certainly merit an ALS intercept. As far as trauma-specific chest pain indications for ALS, again, patient assessment. Do they have severe, unrelenting, excruciating pain? Call for ALS. Do they have a loss of consciousness? Do they have shortness of breath? Do they have some ominous physical assessment finding? Importantly, are there signs of shock? Are they hypotensive? Do they have pale, clammy skin? Vital signs. Specifically, the pulse rate and the systolic blood pressure. When the patient is in hemorrhagic shock, they are losing blood. And the heart rate increases its rate to compensate for the blood loss. It's beating faster to provide more cardiac output to the body. When the patient in compensated shock has tachycardia, they are in class 3 shock and they have lost approximately 30 to 40% of their blood volume. Yes, anxiety and being upset from a car accident can cause tachycardia, but not sustained tachycardia with rates like 120, 130 and beyond. So what you do is you take the patient's heart rate, you divide it by the systolic blood pressure. That calculation is called shock index. And if the math results in 1.0 or greater, then that is a positive shock index. And in the setting of trauma, that is highly suspicious for compensated shock. That would certainly merit transport to a trauma center and ALS activation. The take-home message is assess the patient and make good clinical decisions based on the products of your complete head-to-toe assessment.